Type 2 diabetes greatly increases the risk of cardiovascular disease, which is actually a leading cause of morbidity and mortality in diabetic patients. In addition to this, diabetes also affects kidneys. In fact, 40% of diabetic patients develop diabetic kidney disease that with time progress to end-stage renal disease. The major problem in diabetes type 2 is elevated blood glucose level. So, the major therapeutic approach in this case is to improve glycemic control. In simple words, we have to keep blood glucose level within normal margins. And nowadays, we have a new class of drugs called sodium glucose cotransporter 2 inhibitors, so-called SGLT2 inhibitors. SGLT2 inhibitors provide reduction of cardiovascular and renal adverse events very rapidly. The speed of their effect suggests that it's not only about glucose lowering effect, there are some other mechanisms that provide additional benefits. To SGLT2 inhibitors belong empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. SGLT2 inhibitors cause two central effects. They cause glycosuria and also they induce natriuresis. Exactly these two effects make them so effective in patients with diabetes and cardiovascular pathology. So let's explain the mechanism of their effect. SGLT2 inhibitors act on SGLT2 transporter, which is located in the proximal convoluted tubule. From physiology, we know that blood by afferent arteriole incomes to the glomerulus. In the glomerulus, filtration occurs. Some amount of blood undergo filtration and incomes to the kidney tubules, and the rest of the blood goes through the afferent arteriole back into the circulation. The portion of blood that underwent filtration income to the proximal convoluted tubule, where SGLT2 transporter located. SGLT2 transporter provide the reabsorption of approximately 90% of all glucose molecules that income to the kidney tubules, and its huge amount of glucose. What we have to know about SGLT2 transporter is that this transporter reabsorbs glucose together with sodium. Sodium and glucose absorption provided by the same transporter and occurs at the same time, so they are coupled. But also, because sodium and glucose are osmotically active, they attract water. And this means that together with sodium and glucose, we also reabsorb water by osmotic gradient. Knowing this, let's illustrate this process in more details. When afferent arteriole delivers blood to glomerulus, with blood in comes water, sodium and glucose. Some portion of blood undergo filtration into the tubules, and other portion in comes to the afferent arteriole, and then goes back into the circulation. The filtrated fluid which incomes to the proximal convoluted tubule have the same composition of sodium, glucose and water. In the proximal tubule located SGLT2 transporter. This transporter provides reabsorption of huge amount of glucose together with sodium. And because both glucose and sodium are osmotically active, together with them we also reabsorb water. In fact, approximately 90% of all glucose molecules are reabsorbed by SGLT2 transporter. This 10% of glucose which is left after reabsorption, together with sodium and water, goes further through the renal tubules, and on its way they meet macula densa. The function of macula densa is to control the amount of fluid in our organism. Macula densa simply check the concentration of sodium in the tubule, and if the amount of sodium is below normal, macula densa activates juxtaglomerular apparatus that in turn cause vasodilation of afferent arteriole. With vasodilation of afferent arteriole, the greater amount of blood incomes to the glomerulus. This causes increase in intraglomerular pressure, which in turn causes hyperfiltration. and hyperfiltration greatly increases the risk of kidney injury, and also it can manifest with albuminuria. One of the potential problems with glucose in the urinary tract is that bacteria and fungi very like glucose. They need glucose as energy source for proliferation and growth. So glucose in the urine increases the risk of urinary tract infections. When we prescribe SGLT2 inhibitors, they block the function of SGLT2 transporter. Without SGLT2 transporter, the reabsorption of glucose, sodium, and water decrease. With decrease in glucose reabsorption, the amount of glucose molecules in the blood decrease. We call this glycemic control, and typically we measure glycemic control by decreasing glycated hemoglobin. In clinical trials, it was estimated that SGLT2 inhibitors caused 0.6 to 1% decrease in glycated hemoglobin, from baseline of 7.5 to 9.2%, and this is significant. Why glucose control is so important? Because very high blood glucose level causes non-enzymatic modification of proteins with formation of advanced glycation end products, so-called AGEs. AGEs accumulate in the plasma and tissues, where they cause arterial stiffness and also they decrease elasticity of arterial wall. SGLT2 inhibitors as empagliflozin decrease blood glucose level. By this they decrease the rate of glycation, and thereby they decrease formation of AGEs. First of all, this reduces oxidative stress in tissues, and also it improves endothelial function in case of diabetes. In response to decrease in blood glucose level, organism begin to produce ketone bodies, which is actually a compensatory reaction. When glucose falls, we try to compensate this by increasing ketone bodies production, simply because they have very similar chemical properties to glucose. This shift to ketone bodies production is considered one of the mechanisms for the rapid cardiovascular benefits of SGLT2 inhibitors. Moreover, they reduce hepatic and cardiac steatosis, which is also a common problem in diabetes. The concept is that with lowering of glucose level, we begin to oxidize fats to increase ketone bodies production, and with oxidation of fats, the mass of adipose tissue decreases, and thereby steatosis becomes less severe. Decrease in glucose reabsorption causes energy loss. With loss of energy, we begin to oxidize fats, and thereby fat mass decrease. As a result, we will lose weight. It was estimated that SGLT2 inhibitors, by decreasing glucose reabsorption, cause loss of approximately 200-250 kilocalories per day. In clinical trials, patients on SGLT2 inhibitors lost approximately 2 kilograms, and reduction in body mass is absorbed from the first weeks of treatment. In another research, it was estimated that SGLT2 inhibitors cause loss of approximately 75 grams of glucose per day, which is approximately 300 kilocalories daily. And as we know, increased body mass is a typical feature of type 2 diabetes. So it's another reason why they are so effective. Because we reabsorb less glucose and sodium, the reabsorption of water decreases. This causes decrease in plasma volume that straight away causes increase in hematocrit. Also, decrease in plasma volume causes decrease in blood pressure. The reason is that blood pressure is equal to cardiac output on systemic vascular resistance, and cardiac output is a stroke volume on heart rate. So, with decrease in plasma volume, stroke volume decrease. Thereby, cardiac output decrease, and this causes decrease in blood pressure. So, another effect of SGLT2 inhibitors is decrease in systemic blood pressure. If we do not reabsorb glucose, water and sodium, they will go further through the renal tubules. First of all, this will cause increase in amount of water, sodium and glucose in the urine. Because the excretion of water increase, this will cause diuretic effect. And because the reason of increased water excretion is increase in excretion of sodium and glucose, which are osmotically active substances, we call this osmotic diuresis. So the point is that because the reabsorption of glucose and sodium are coupled, with inhibition of SGLT2 transporter, the reabsorption of sodium decreases. This effect typically manifests by an increase in urine volume of 300 ml per day for the first 2 to 3 days. And this diuretic effect is caused by osmotic diuresis due to the glycosuria and natriuresis. With osmotic diuresis, plasma volume decreases, and this manifests as increase in hematocrit. Also, with decrease in plasma volume, systemic blood pressure decreases, both systolic and diastolic. Decrease in systemic blood pressure improves endothelial function, and also it causes decrease in vascular stiffness. As we see in case of SGLT2 inhibitors, there are a lot of cardiovascular benefits from a glucose-lowering agent, which is quite unique. Because reabsorption of sodium decreases, the amount of sodium in the renal tubules increases, and this significant change in sodium concentration is sensed by macula densa. In response to increase in the amount of sodium, macula densa inhibits the function of juxtaglomerular apparatus. This provokes vasoconstriction of the afferent arteriole that in turn causes decrease in intraglomerular pressure. The lower the intraglomerular pressure, the lower is the hyperfiltration, and thereby the lower is the risk of kidney injury, and the lower is the albuminuria, so the amount of albumins in the urine will decrease. So SGLT2 inhibitors induce dose-dependent reduction of glomerular filtration rate. The mechanism we already discussed. The reason why it's important is that hyperfiltration is the risk factor of a single nephron level progression of kidney disease, and also it can manifest as macroalbuminuria. So SGLT2 inhibitors, by increasing distal renal sodium delivery, provoke vasoconstriction of afferent arteriole, and by this we reduce hyperfiltration. Interesting that renin-angiotensin-aldosterone inhibitors also decrease glomerular filtration rate by a reduction of intraglomerular pressure, but they cause vasodilation of afferent arteriole. So the idea is the same, but the mechanisms are different. Decrease in intraglomerular pressure reduces renal hyperfiltration, and also it decreases the amount of albumins in the urine. Because glucose reabsorption decreases, the amount of glucose in the urine increases. It creates problem because bacteria and fungi very like glucose, and with increase in glucose delivery to them, their growth and proliferation increase, which significantly increase the risk of urinary tract infections. For today, we know that the most common adverse effect of SGLT2 inhibitors is mycotic genital infections, usually caused by Candida species. This side effect occurs approximately in 10% of women and 5% of men. So females on SGLT2 inhibitors are at the risk group. In clinical trials, it was estimated that patients on SGLT2 inhibitors have 2.5 to 6 times higher incidence of urinary tract infections compared to controls. In addition to this, SGLT2 inhibitors can block the function of GLUT9 transporter, which inhibits the reabsorption of uric acid and thereby cause decrease in uric acid level in the blood. The fact is, SGLT2 inhibitors decrease plasma uric acid level. The mechanism is not fully understood yet, but we know that to absorb uric acid from the urine into the blood, urate-1 transporter should reabsorb urate anion into the tubular epithelial cells, and then urate anion should be transported into the blood, and this transportation is provided by GLUT9 transporter. It is believed that SGLT2 inhibitors can block GLUT9 transporter, and without GLUT9 transporter, the transportation of urate anion into the blood decreases. As a result, the level of uric acid in the blood decreases. So it's the mechanism how SGLT2 inhibitors reduce plasma uric acid level. In addition to this, SGLT2 inhibitors can decrease the severity of inflammation and oxidative stress in tissues. As we know, inflammation plays a crucial role in development and progression of renal dysfunction. SGLT2 inhibitors can decrease the production of pro-inflammatory cytokines, and by this they can reduce the severity of inflammation. Also, because SGLT2 inhibitors have some antioxidant properties, they reduce the release of superoxide in the myocardial tissue. Superoxide is a free radical, so SGLT2 inhibitors can decrease the severity of oxidative stress, and subsequently this will decrease inflammatory processes in myocardial tissue, and thereby it will decrease myocardial fibrosis. Overall, SGLT2 inhibitors are extremely effective drugs, especially in patients with diabetes and cardiovascular pathology, and the major drawback is increasing the risk of genital infections, so we have to keep this in mind.